live stream, Simon, please, and we'll begin.
Yeah, we're starting the live stream now.
Good afternoon, everyone, and welcome to all members of the board to our 74th meeting of the CCG, and also any guests that we have today. And I'd also like to welcome the general public. We don't have any questions pre-notified from members of the public, but as always, a slot is dedicated to hearing any questions or observations. So that's probably worth noting for anyone listening who may wish to ask a question in future meetings. So I'd like to introduce myself. I'm Pam Donnelly, and I'm stepping in for Hassan Chowhan, who's on holiday today. So he's asked me to chair this board meeting on his behalf. Because of the numbers of people involved, I wasn't planning to go round the whole board for introductions, but we can all see who's in the meeting from the attendance list. So let's make a start. Hopefully you feel you've been welcomed and we've had the introduction from me. Apologies for absence. Well, obviously Hassan's not here, our chair, he's on holiday, so he's given his apologies, as has Patrick Higgs from Essex County Council. So we move on to declarations of interest. We do have in our agenda meeting packs a very comprehensive.
Pam, sorry, can I just interrupt, because I just don't think you're quorate because you haven't got a majority, because you've got 1, 2, 3, 4, 5 directors, and you've got 1, 2, 3, 4, 5 other people, because I can't see that Prasanth, Frida or Faraz are in attendance.
Let's just check. So for anyone listening in, apologies for the delay, but we will need to invite those individuals into the meeting. So we'll take a slight pause in proceedings whilst Joe invites them in. And then perhaps, Joe, you could let us know when we are quorate.
Hello.
Hello, who's joining the meeting now?
Frida's here.
Yeah, I'm trying to get in, actually. I seem to be having problems getting in, but I will get in, don't worry. I'll be there.
Well, we can hear you, that's the main thing.
Oh, okay. I don't know what's wrong with my computer.
So we're recording the meeting now, and we are on live stream.
Okay, let me get on though. I'll get in. Okay, thank you.
Can we invite Faraz, please, and Prasanth?
So I have invited them all now, but I don't know if they're accepted.
Let's take a break until they do.
I think as long as Frida's here, which she seems to be, you're all right, so.
Let's hope that our other two colleagues join us shortly, but now we're quorate, we can progress. Joe, you comfortable with that?
That's fine, yeah, thanks, sorry.
Apologies for the interruption. So declarations of interest, I was just explaining that we do have detailed declarations of interest in the pack, but are there any additional ones to declare today in light of agenda items? It doesn't seem like it, so we'll progress. Item 4, minutes of the previous meeting. They're very long and detailed minutes, and we just need to satisfy ourselves of the accuracy of those minutes and accept them as an accurate reflection of our last meeting in June, on the 8th of June. So are there any comments with regard to accuracy before we confirm them? Can't see anyone indicating that there's a problem, so thank you again, Joe, for such good minutes and in a lot of comprehensive detail. Matters arising and review from the action log of our last meeting. There are no actions outstanding. They've either been closed down or there'll be items on the agenda today. So we'll move on, if we may, to item 6. So this is where we hear a verbal update from Dr. Ed Garrett on events since the last meeting. So I'll hand over to you, Ed, please.
Thank you, Chair. So just a list of things that I'll talk through, and very happy to take any questions on any of these updates. So firstly, the Chief Medical Officer, Chris Whitty, has published his annual report, and the report is on coastal communities, and in particular some of the challenges that coastal communities face. There's a paradox that where coastal communities obviously have beautiful environment, clean air, there's often very poor health at the same time. And in his report, Professor Whitty has written a chapter on Clacton, not only to talk about some of the challenges, but to highlight some of the excellent place-based work that's taking place there, with contributions from many partners, but including the CCG. So it's a really strong endorsement of the work we're doing there, and it's great to have that work highlighted. Secondly, there's now a new Secretary of State for Health and Social Care, Sajid Javid, who's in post, and he's appointed a new Chief Executive for the NHS in Amanda Pritchard, who will be the first female Chief Exec of the NHS in its history. So we wish Amanda well in her new post. One of the early decisions that the Secretary of State has made is around integrated care system boundaries, and he's decided that in the east of England there will be no changes to the current ICS boundaries on the basis that all of the systems are moving forward, and it wouldn't make sense to disrupt them. So we'll be moving forward on a Suffolk and North East Essex footprint, and the new statutory arrangements will be in place from April. Probably the three big operational areas for the NHS nationally and locally would be the vaccination programme. So we've now given 2 jabs to over 73% of our adult population, and we're making very strong progress too on our 18 to 29 cohort with first jabs, and that's been a real area of focus for us. We're planning as well for phase 3, which is where we'll be giving a programme of booster jabs from the autumn onwards, and I'm very pleased that providers have come forward in North East Essex to continue all the work and the progress that has been built so far. So a very strong progress. I think the biggest area of focus and concern is in certain wards in Colchester, where we've got lower uptake of the jab compared to other areas of North East Essex. So we're working with Colchester Borough Council and Essex County Council and other partners to look at how we can increase uptake in those wards. So thank you to everyone involved with that. The second big area is urgent and emergency care pressure, including COVID and including indeed mental health demands. So we're seeing significant pressure in all sectors of the health service and the health care sector and the voluntary sector. And a manifestation of that is the numbers of people going through our emergency departments. Regrettably, a significant number of people in mental health crisis that are ending up in our emergency departments. So it's never been more important to have that integration of physical and mental health. In terms of COVID numbers, whilst they may be cooling, the rate may be cooling nationally. We had 28, I think, COVID positive patients in Colchester Hospital yesterday, which is a big increase from where we were a few weeks back. So still a significant issue within the local NHS, and impacts on the third big area of work, which is elective care. So it really restricts some of the capacity that we have where we have COVID patients and having to self-isolate or isolate them. So in terms of elective recovery, we have significantly long waiting lists as a result of the pandemic, and that's a described in the board paper, which we'll come on to, and is a national issue. We are an accelerator area, so we have been working very hard to firstly reduce the waiting times, and we've reduced it from, I think, 53 weeks down to 40 or 41 weeks, so making progress there. And we've significantly reduced the number of people waiting over 1 year in our ICS, so that's good, but the overall waiting list is still growing, which is a real concern. So progress in some respects, but still a hell of a lot to do. And then finally, since we last met, the new arrangements for our community services went live in North East Essex, and so far so good. I think it'd be good to have a proper update on that and look at the performance data once we're a little further down the line. But thank you to everyone involved in mobilising that service. That's all from me, Chair. Thank you.
Thank you, Ed. And several of those themes that emerged in your update will be picked up later on. And also, I think we would very much welcome a report on the real hard work and effort that's gone into mobilising the new contract, community services contract. I know a huge number of people have been involved to make sure that continuity of care is a priority. So let me just see if anyone wants to comment or ask questions to Ed. No, I don't think so. So just leaves me to thank you very much for your report.
Thank you.
Ed, and we'll move on now to item 7, which is the Health Forum Committee report. Have just checked with Myrna before the meeting, and she's very happy to position the paper as read. So are there any questions for Myrna on the Health Forum Committee report? You'll see when it's a short report, a very simple, easy read, but you'll see that Myrna refers to some of the challenges of working in communities during the pandemic, and also notes the importance of receiving updates on how the future shape of the NHS locally will move forward. So we'll note that report unless there are any questions. And there is someone indicating. That's Ed. Over to you, Ed.
Yeah, thanks, Chair. Myrna, from your perspective, from a community perspective, what thing is kind of concerning you most? What feedback?
Well, obviously, the waiting lists for people waiting for care is concerning, and I know it's all over the country, so it's it's not just here. But let's I think basically there's a lot of concern about whether it's safe to do things that we're now told we can. There's a lot of anxiety, especially among some of the elderly people, about whether they can go about their business more, and I think that's the main things that are worrying people, and whether we should be worrying the hospitals and things at this time. I think some people have been hanging on to things, and it's been difficult to get appointments at the doctors, and they've been hanging on to all these things, and now all of a sudden they're nervous about sort of even now going to doctors. It's perfectly safe. I know I've been myself this week for a blood test, but it's perfectly safe. But everybody worries, and I think how we get over that, how we get things back to normal, I don't know. It takes time.
Thank you. I think you've reflected the concerns a number of us feel, don't we, in our own communities and families and friends. Thank you. Does that answer your question?
It does. That's perfect. Thank you.
Okay. Ed, I know you'd like to. Jerry, you'd like to ask a question.
Yeah, I noticed Myrna's report mentions concerns about how the Health Forum group or patient rep groups are going to be involved with the Alliance, but it doesn't mention the ICS. I wonder if there's any talk about how patients are actually going to be involved in that body in the future.
There hasn't been in our meetings so far, and I do think there is a difference between, especially with our members, meeting with electronically rather than sitting in a room where people tend to feel, happier to ask questions. And so it hasn't. I mean, it's always mentioned in the reports that I do from the various meetings that I go to, but I don't get any questions on it. So
Thank you.
Hope that answers your question.
Thank you, Myrna. Lisa, would you like to ask a question?
Yeah, just to respond really to that question around public and citizen and patient involvement in the ICS level. And I haven't got a clear answer at the moment, if I'm honest with you, because it's an emerging thing. But I attended North East Essex Quality Committee the other day to talk through the move and the requirement, and it's absolutely what we all want to do, to understand what the population wants at a system level around place-based. So actually, what do the people in North East Essex want, rather than looking at experience just from provider level? We're very good at looking at how patients experience end-of-life care at ESNEFT, or how they experience patient transport service, but we never properly, routinely and consistently look at how does the public and patients experience the whole of end-of-life care, from acute through to transfer home, through to care home, or through to home and the community service, and the whole pathway. So understanding how the population feels and what they want and what matters to the population will be a massive part of how we move forward, but it will be done at different levels. So absolutely through the kind of the locality and the neighbourhood team approach in Clacton and Colchester and at different places. Then at alliance level, the ICS level, we'll be looking at variation and ensuring equity of access to services and to quality, rather than trying to understand how each part of the population across the whole of Suffolk and North East Essex experiences care. We'll be looking more at the variation in experience, and also working closely with Healthwatch, who will be the regulators that will be holding us to account for that work. So, sorry, that was a very long-winded answer to the question, but it's something that we're thinking a lot of as I'm talking. Thank you.
Thank you, Lisa. It might have been long-winded, but it was also very reassuring. I hope Myrna feels the same as I do, that lots of opportunities, as you've described. Max.
Thank you, Chair. I think there's an opportunity for patients to become involved with the various ICS boards, and up until recently I was chairing the cardiovascular board, and we were certainly looking for patient representation on that board. So I would strongly encourage that we get our sort of patient forums, put a call out, if you like, to them and say, look, actually we do need involvement certainly in the clinical boards that we've got set up across the ICS.
I think that's an important point, Max, a real opportunity for new people to join the patient forum environment and have a voice as the NHS shapes up in our area. So thank you. And thank you, Myrna, for your report. So we'll move on then to item 8, which is a presentation from the Medicines Management team. And I'd like to welcome Lisa Stevenson and Oji, who's with us today. Both have joined our meeting. And I assume that either Lisa or Oji, you'll be sharing the screen so that we can all see the slides. But I'm going to hand over to you, Oji, for an introduction.
Thank you, Chair, and good afternoon, everyone. My name is Oge Chess. I'm the Deputy Director for Primary Care Medicines Management. And I'm here to give this presentation to support Lisa, who is a member of my team. She's our quick lead. Can you all see the screen now?
We can. It could do with being a little bit bigger if you.
Yeah. I'm putting it on slideshow as we speak.
Thank you. Thank you.
Not as responsive as I want it to be.
There we are. That's perfect. Thank you, Oji.
Lovely. Thank you, Chair. So we're here to really give a snapshot of medicines management and its dealings in currently as up to date in 21-22. And just to say that this department sits under the able hands of Pam Green. So the medicines management team consists of a senior element, 3 pharmacists and a senior pharmacy technician that help deliver the aims of the team. We've got 8 practice technicians who kind of do the doing, the core face in our practices, and we've got an IFR approval coordinator. What's IFR? These are the individual funding requests, those difficult needs that we need addressing, that require going to another panel to seek approval and funding. So really, what medicines management seeks to deliver across North East Essex Alliance and the ICS where applicable is to ensure that there's an evidence-based approach to prescribing, that we seek to deliver efficiencies in the prescribing budget. We want to ensure that our population are safe when it comes to medicines they use. We want to ensure that they do not have too many medicines. And I guess the key thing is that the team seeks in 21-20 and 21-22 to be visible to all practice, to all users. So we're working with the voluntary sector where applicable, with our primary care networks, etc. So I'll then pass on now to Lisa to talk about the individual work streams that are relevant to the population we serve, as well as at the end of that we'll take some questions. So Lisa, over to you, and tell me when you want me to change the slides.
Hello, everyone. Good afternoon. Thank you for having me. So, as Ogie was saying, we want to be very visible. And this afternoon, some of the areas that I will go through will be areas that we have been working on, or also things that are of a national interest. So the first bit here is the antibiotics antimicrobials. We've been working on this for some time. And our main aim of this, because this is not just a Northeast Essex initiative, this is a national initiative, and we all need to be antibiotic guardians taking care of the antibiotics. So for example, our GPs or healthcare professionals that we see should only be prescribing it where it's clinically indicated, and not just giving it to us because we want it, or not looking into it or having the discussion. There are conditions that are viral and we can take care of ourselves. They will give us end dates of when we should approximately start to feel better and when we would come back to them. Inappropriate use as well is a risk for Clostridium difficile. This is a disease that affects the gut and it causes hospital admission. And sometimes when we do get there, we can be there for a long time before we do get better. NICE do develop clinical visual summaries that make it easy for our clinicians to look at and to see where we fall in based on our indications and the problem that we present with. And they then decide from that what would be the best course. Would it be a delayed prescription? Would it be self-care? Their target do develop patient information leaflets as well, which help us to take care of ourselves. Next slide, okay, please. Another area that we have been working on is around respiratory. And so it's not just around the low carbon inhalers, but this has been a national interest again. And in this one here, we're working with the ICS. We have started working with them, and it is to reduce the number of inhalers that cause detriment to our environment. And we need to have a net zero by 2040. And as this slide is showing us, one of this blue inhaler is a preventer inhaler, the top one there, and that is equivalent to 175 miles. But the other one to the bottom, which is a low carbon inhaler, is just 4 miles. So it's working with our clinicians to find the best inhaler for us, but also collaborating with drug companies that they give us the options to make it easier as well. Next slide. So as I mentioned, we've been working also with the Royal College of GPs and the SNF respiratory consultants in Ipswich and East Suffolk, so that we can develop an action plan of how we can tackle the use of low carbon inhalers to reduce our footprint. The main thing, as I was mentioned, it was the blue inhaler is a reliever inhaler. And one of the things we have been having a problem with in not just North East Essex, but it's been a big problem in North East Essex. We're outliers when it comes to preventer inhalers or the reliever inhalers, because sometimes people are requesting more than they need. For example, children, if they have split households, instead of the parents working together for the betterment of the child, the clinicians have got to prescribe multiple inhalers. And then every month it's multiple inhalers. But also, if we're using many of our blue inhalers, it's an indication that our condition is not, especially if it's asthma, it's not being well controlled. So it's getting that into perspective when we see the healthcare professionals having that discussion with us and helping us to realize what it is we need to be on, but it also would then contribute to a low carbon footprint. Another big area, I suppose you've heard about it before, it's around the pain and our opiate prescribing. So what we have done recently, maybe in the last 12 to 16 months or so, we've developed a suite of documents that can be used by clinicians and patients to support the prescribing of opiates. So it's only being we recommend it's only being prescribed when it's actually needed, and to also have documents to support patients with self-care, when to deprescribe, and other things that they can do, and also how we initiate and stop at the right time so that we don't leave patients on stuff so that they can have an addiction problem potentially developing. So we have secured some funding to work with the Drug and Alcohol Service from Essex County Council so that we can support GPs going forward with reviewing the patients and helping them to get off of opiates. And this would also be more to the patients with complex medical needs. Self-care. This has been a national, on the national agenda for a long time. And again, this is an area where North East Essex, we've been having problems with getting our patients to self-care, and working with our GPs and the hospital, everybody who's a prescriber, to work together to recognize that when we can self-care, to advise us that we should be self-caring. On this slide here, you would notice that I said that patients who are seen, they can be seen in another setting, for example, a community pharmacy. And if they're seen there, we will have more time freed up for the GPs or the other healthcare professionals to see more sicker patients, to look through the notes, to do more for us, because our minor ailments are with the people who can take care of us. We are working with the social prescribers, which you will find in the PCNs. We're having those people as well, and they will direct us to areas where we can do mindful meditation, yoga, community gardening, anything that will help us take care of ourselves. Oral nutritional supplements. This has been another big area that we've been working on over the year. You might be thinking that I've got lots of big areas, but they've all been very big for us in North East Essex. And we're an outlier when we compare to England average. And we have found that within nursing homes, we are prescribing more. We've had examples of where the dentist should be seeing the patient, but we're giving supplements because the patient can't chew. So we're giving supplements instead of food first. So we're working collaboratively with local specialist dietitians and Oviva to have a service that we can ensure people are reviewed appropriately, stopped, teach people about food first, encouraging nursing home staff that food first is more is better than having a supplement. Ensuring patients are reviewed using the MUST scores and come off of SIP feeds when it's appropriate. Polypharmacy. This is when one person is using lots of medication, but lots of medication unfortunately leads to more side effects. And you will find that if you are on medication, our doctors, our practices will be inviting us for medication review. During the medication review, this is a discussion between the patient and the healthcare professional, and we come to a shared decision about the treatment. So polypharmacy is not all bad, because sometimes we have lots of different things going on with us. And if that has happened, then it would mean that we would look to make sure that we're giving you the right medication for the right conditions. But sometimes it's problematic because we're using it, but we're not benefiting from it. So we need to review that to make sure that we're giving you the best. It's we subscribe to something that's called Prescribing. It's a platform which helps us with tools to support medication reviews. And we've been asking the PCN pharmacists to sign up to this. Lots of them have, if not all. And there's webinars to support how they can do these reviews. So during the medication review, you will be asked, why are you taking the medication? So it's that so that you understand. And the healthcare professional will still ask those questions to make sure that they understand, especially if you've seen somebody else before. They'll be asking if you have side effects. They'll be discussing risk if you take it for the long term. They'll be looking at the right dose. So for example, if you're saying, oh, I'm really not feeling well on this, they'll be looking, is this dose too much for you? Or I'm not getting any benefit. They look to see if the dose is low. Again, lots of medications we take sometimes affect maybe our liver, maybe our kidneys. So we'll be checking to see whether your kidneys and liver functioning right. So you need, when you get the blood test, we're asking patients to come in and get these blood tests because it's a big part of taking the medication. And then we look to see if it's interacting with anything else. It might not necessarily be something that's prescribed, but it might be something that you've bought. And then whether we should continue taking it. But by asking these questions on a regular basis, we're making sure that patients have the right amount of medication for their condition and they are benefiting from it. There's also something now that we call a structured medication review. It's a little bit different in that we do go through it in a more compartmentalized model, but you kind of find the high-risk patients, for example, we look at them and you look at all the medications still, but you would start off by looking at a group and then work your way through it. So for example, if you're in a care home or if you were frail, that's where we may start, but we will look at all of your medications. At the moment, we are supporting the PCN pharmacy workforce with this. We're doing a crib sheet for them so that they can see which groups of patients they may want to prioritize, how they want to do these reviews, what they probably want to do first before they start the reviews. And that is how we are supporting the team on a whole.
Thank you, Lisa. Thank you, Ogie. I suspect that presentation has generated a number of questions. I certainly have one, but before I start off, perhaps I could turn to Pam Green, for a few closing remarks.
Thank you very much, Chair. I think it's really important to note that the team within the medicines management team manage a huge amount of risk financially and clinical within their scope of work, and they're very much embedded as part of the primary care teams. I'm incredibly proud to be the leader of a medicines management team of the sort that I have, and we've been through an incredibly challenging period around the COVID vaccination programme, and also the change in format of GP practices and remote working. So the support that we have offered has had to morph and change through COVID, and the skills and the asks of our pharmacists as well as the pharmacy support workers through COVID was significantly changed from their usual work. So huge thanks to Oge and her leadership to the team, as well as all the other leaders within that team. It's incredibly challenging when you're working remote from the patient and not able to have the direct conversation with the patient. So the relationship with our GPs, our nurses, our specialist prescribers is incredibly important. And we are seeing a huge amount of collective work across our ICS now coming to bear fruit. We've got support for the clinicians within the system, and I think it can only be positive moving forward. But it must be a team that's recognising the transition to ICS as having huge value around the quality and safety of prescribing within our system, not just in general practice, but also within our hospital and community settings. So thank you very much for the presentation, both, and all the effort that you put in to preparing that.
Thank you, Pam. And Lisa herself, you said you've been dealing with a number of really significant issues all along one aside of each other. So we have a number of questions from members of the board, but could I kick off, please, if I may, Lisa, with a question about this is change, and it's always difficult for some stakeholders, particularly patients, to accept change. And I wonder, how do we, in your opinion, how do we give our communities confidence that this change, how can we get them to accept advice and guidance, often from different people in different settings, in different ways? And do we need a campaign of some sort to try and encourage behaviour change and acceptance of new ways of working? Lisa, may I ask you that question, and then I'll turn over to my other speakers.
Yes, so I do believe we need to do something of some public facing, because I put myself as a member of the public and I don't know who the CCG is, and I probably would know who the ICS or an alliance is. And I think we do need to make ourselves very public so that I understand as a patient what is being said. Next thing I think we need to do is to work collaboratively. So if I see somebody in the hospital, Mr. Jones says, Lisa, you need to self-care with some paracetamol. I must be confident that that is the right advice. I shouldn't feel that, and I can go and knock on my Dr. Hickman because I can break him down to give me the paracetamol. I need to understand that. And we can only understand it if we paint the big picture to the patient. I think it's a big change from what we have been accustomed to and what we have been saying to everyone as the NHS. We will look after you. We will still look after you, but there's parts of it which you need to do yourself. And it's how do we get that message? Is that when you see me as a pharmacist on the counter, I don't say, oh, yeah, because we get patients calling us up and say, the pharmacist said in the community that I can get this from my GP. So it's all of the sectors coming together with the same message to get it over to the patient. So they know we're still taking care of them, but sometimes we give advice and sometimes we write a prescription.
Thank you, Lisa. I think what you're describing there is a very challenging integrated communications campaign that's going to need some real effort and will behind it. But let's turn to our patient representative. Myrna, would you like to speak? And then I'll turn to Max. Myrna.
Yeah.
Myrna, at the moment you're still on mute.
To unmute. Oh,
Yeah,
done it now.
please go ahead.
Yeah,
I can hear you now.
Something that's worried me for probably years and years and years is something that when patients go into hospital, often they're given new drugs for whatever, whatever's wrong with them, without really any review of what else they're on. And I think almost, and it's impossible to do, but almost when people come out of hospital, somebody should look at what medication they're on and make sure that the new drugs are compatible with what they're already taking. But it doesn't seem to happen. They just added on. So people suddenly find that if they have several trips into hospital, they've doubled all their medications. And it's very difficult. And I don't know how the GPs would have the time to do this or anything else. And it's probably going to be impossible. But it's worried me for some time. And, it's obviously part of probably what you're looking at.
Thank you, Myrna, and perhaps Lisa or
Yes.
Ovi could give you some reassurance on that point.
I'll take that. Thank you, Lisa. I'll take that one. So I guess in terms of that, is that there are two things. When a patient goes in, ideally there's guidance that there should be a medicines reconciliation, a process to reconcile what they were on before they went in, and there should be a process of a review on discharge. Many a time, workforce pressures do not allow these things to happen. However, there is an expectation in the ICS to have an integrated, what's it called? IPMO, Integrated Prescribing Medicines Optimization Lead, that will ensure that all the systems that enable medicine safety, medicines efficiency to occur and exist across the system, and it will integrate with all the roles and functions. So in primary care, where you will reside, there would be a PCN workforce that would have the remit to review your medicines on discharge, so that in primary care, there's an accurate record of what you should be on, what was new and what was stopped. So even if it was missed in the hospital, it will be picked up in primary care. Does that kind of clarify? So we're working towards that. We're going to streamline medicines management in the new ICS infrastructure, but it can still happen, and it will, and it's supposed to still be happening now in primary care with your PCN workforce supporting the whole flow of medicines across all interfaces.
So we've heard there, Myrna, that it should be happening, but a real priority for the new arrangements. It goes back to something Lisa said earlier about making sure there's real engagement with the public so that the experience of patients is fed into that. So thank you for asking that question. Max.
I think Frida was next, but I'll take it.
I'm sorry, Frida.
Yeah.
Are you happy to wait? I'll go with Max and then Frida.
Yeah, that's fine.
Yeah, and I just wanted to say that thanks very much, Lisa, for your the presentation. I think it's the work that the medicines management team do is absolutely excellent. There's quite a close working relationship between the team and the clinical review group, which I chair, and we get reports every week from medicines management. I think what the issue that Myrna sort of raised, I would hope that actually all medications are reviewed in primary care that have been started in hospital. I would have thought that is something that is normal for general practice, certainly normal for me if I have to review a discharge summary, so that we don't, it's not just added as Myrna says, we do actually look at the medication, review them and make sure that they're appropriate, and that we should continue prescribing, because all discharge summaries are looked at in primary care. Thank you.
Thank you. Sorry to keep you waiting, Frida. Over to you. Thanks, Matt.
No, sorry, I'd also like to say that over the years, I have noticed the increasing importance of the medicines management team in my practice, my personal practice, and in my general practice, and I think they have developed into a really strong supportive role with GPs, and I think that there has been a a closer working relationship with pharmacists, and that's been developed under the current CCG Medicines Management Team with the CPCS scheme that's just started, which is when we can send our minor ailments to a pharmacist on a triage-based system, which has been really useful in the pandemic. More recently, of late, and also the PCN pharmacists that we're now recruiting through the PCNs can do what Myrna's suggesting. Having said that, I agree with Max that I think what you're saying, Myrna, is specific to a single practice, because in my practice of 30 years, I have never not looked at a medical discharge and changed the medicines over if they needed to be done, because that's my duty of care to my patient. And I'd be really concerned if me or my colleagues weren't doing that. I'd just like to add that we became first in the second year running, and as the best practice in North East Essex. I'd just like to add that in while we're here. No one's congratulated me yet for my second year in a row, Ed. Anyway, the point is, then, Myrna, I'm really concerned if that's been your experience, because that should not be the case. The duty of care for the GP is to make sure those medicines are realigned on discharge, and it's very worrying when that doesn't happen. And there are times I just close my eyes with absolute horror at some of these stories. But anyhow, moving forward, I would like to say that we are working much more closely with pharmacists than I've ever known, and can only be a good thing. And I thank the medicines management team, particularly the two ladies today, for allowing that and developing those processes. I will end on a slightly negative note, though, in terms of the general public. It is incredibly hard to change habits of the general public, no matter how hard Lisa or any of us try to tell the patient, no, you don't need that. Yes, you can get it over the counter. Yes, you might have to pay. And yes, you might be over 60. They will not accept it. And until the general principles of welfare state and health provision in this country are changed in certain ways, people will always see this as a free-for-all. And no matter how many efforts you all make, or we make, or how many PR campaigns, if people can get things for free, they will demand them. And they can be really abusive and difficult at the front line. And whilst, yes, you can say, oh, yes, we can refer blah, blah to the POWS team, it's hardly fair on my colleagues like Lisa to have to put up with the absolute awful behaviour that some of patients have when they're asked to pay for something, which actually could cost them about 50 pence, as opposed to a free prescription. They will still kick off. So the appalling behaviour of the general public never ceases to amaze me. And I can only say I have 4 more years to go before I retire, and I don't hold out any hope. But I think the efforts of the medicines management team have been excellent.
Well, thank you for acknowledging the efforts of the medicine management team. I'm sure those comments are very much welcomed, and I know Ogie would like to come back. But I think what I'll do, if you don't mind, Ogie, is bring in Prashant, and then maybe you can respond in conclusion. And several people have said well done. So on behalf of the board, well done. Frida, that's a great achievement. So over to you, Prashant.
Okay. Can you hear me?
We can, thank you.
Yeah. Frida, congratulations. We're not far behind. And I must congratulate Ogie and Lisa and Pam. What a wonderful presentation. Such difficult concepts of polypharmacy, patient safety, medication review dealt with in 3 or 4 slides. Absolutely superb. Yeah, I can't underline any more about patient safety, and those concepts which you have raised, Lisa, are all about patient safety, and we should be doing the right thing in the front line. Although I concur with Frida that in the front line, especially the reception staff in primary care, do take the brunt of the vitriol spouted by the general public, probably because they've been waiting for a long time, but we, I think, are in the front line taking it all. But thank you for such a superb presentation.
Well, okay. Would you like to conclude and
yes,
recognise those comments?
Yes, I want to say thank you very much for the kind remarks, and just want to, on the back of what Frida said, just to also thank our general practitioners, and I think Frida's practice is one of them. She mentioned the GP community pharmacy integration consultation service. That's a service where we have supported the training of reception staff to be able to triage patients that are minor illnesses and direct them to community pharmacists. And this is part of a national integration process. It supports the whole ICS collaboration agenda to ensure patients get seen at the right place by the right workforce. And we've been training our reception staff, and hopefully, Prashan, it will help address, the pressure and help give them some skills to be able to manage those difficult patients. And just to say, thanks to the uptake of our clinicians, North East Essex is the highest CCG across East of England on the uptake of that initiative to free the primary care workforce and direct medicines interventions to the right place in the first instance. So just to say thank you to our primary care workforce that are supporting this initiative. So yeah, thank you, Chair. That's what I really.
Thank you. Thank you. Myrna, your hand's still up. Do you want to come back? No. OK, so I think we've concluded that item. Thank you both, Lisa and Ogie, for joining us today.
Thank you for having us.
So we'll move on to item 9. This is terms of reference for the F&P committee. Martin, do you want to say anything, or are we just assuming these are as read?
No, it's a one-word change, really. It's just to make sure that there was some potential misunderstanding on what would describe choracy of the committee, and we've just cleared that up by basically saying who needs to be there to be chored.
Thank you. So nothing to debate on that issue. Thanks, Martin. So before we move on, can I just check that since the meeting started, Joe or Simon, we haven't had any questions notified to us from the public?
We have had one question that's literally just come in, and I can give that to you now if that would be helpful.
Yes, please, Simon.
OK, so this question comes from Mr. David Carley, and he's written to us to ask the following. I have recently moved, and my old pharmacy used to be able to receive my regular prescription, and I've collected it within a day, but my new pharmacy cannot complete it on the same day. And his question is, why is that?
Thank you. And neither can mine. So that's a question I'd be interested to hear the answer to. Very good timing, given that we're talking about pharmacy. Who's able to answer that one? Is that something? I think Ogie and Lisa have left us. So Pam, could you pick that one up, please?
Yeah, certainly. So we just need to make sure that the practice where this gentleman is registered is in the electronic prescribing programme, and if there is any issues with the practice dispensing to that, as well as the designated pharmacy. So if Simon, you can give me the details, we can check at patient level what's happening. So it should go redirected to the nominated GP practice. It may not happen as quickly, depends at the moment, depends how quickly the practices are able to process prescriptions, but it's the quickest and most efficient way. We have high take up of it locally with our practices, so we can look into what's happening there.
So, Mr. Carley, obviously we can't enter into the discussion of your own situation in a live broadcast, but I hope you feel reassured that if you can share your details with Simon, our Chief Operating Officer, Pam Green, will make sure it goes to the right place. So thank you for the question. Anything else, Simon, or is that it?
No further questions. Thank you.
Okay, thank you. So we'll move on to our operational reports, of which there are a number, and we're going to start with Paul and the integrated performance report. Would you be able to pick out the key headlines for us, Paul? Again, sure. With all of these operational reports, we'll assume for the sake of efficiency that they have all been read, but key points would be welcome.
Thank you, Chair. So, of course, as you quite rightly put, this report was significantly discussed at the Finance and Performance Committee, and I'm sure Martin will want to come in at some point after I finish speaking about anything that I might have missed. There's probably 2-3 things that I'd like to pick out the report. First of all, the new system oversight framework, and I'll say a few words about that. I think Ed has already sort of mentioned elective recovery, and I think I ought to say something about that, given it's one of our in terms of recovery. And we also sort of talked a little bit about mental health at the meeting, so I might say a little bit about that too, if that's okay. So just to note, really, the new system oversight framework has just essentially been published following consultation. And really, this is a health-focused performance framework. And I think it tries to essentially to give clarity to how NHS and I are going to monitor performance as we move forward. It's fair to say that at this point, it's probably for the remaining 6 months of the year. It will change again in 2023 when the ICS is coming to being. So let's await that change. It tries to reinforce the system-led delivery and integration. It very much points toward partnership working, builds on to the various other documents like operational planning guidance, etc., and tries to bring it all together. I have to say at this point, though, many of the measures are not of no surprises. They're very health focused, as I said, but I'll come back to that in a second. I think the other key for me of that document are really around the fact that it points towards far greater collaboration nationally with bodies like CQC, and I'm sure you've heard Lisa know that is. We talk about the increasing to the involvement with bodies like CQC. It's important to point to that it's moving away from a specialist measure approach to performance, and it talks about single integrated recovery support program. That coded message to say we'll bring various supporting people like NHSI improvement and other bodies to try and support in the level of improvement. So it won't just be do better, work harder. It's very much about how can we support is the ethos of the paper. We've talked very much along many of the things we talk about that it picks up performance through a number of lenses. It talks about quality and outcome and access, and we've talked about previously. It very much talks about people. It talks about preventing health and health inequalities, finance use of resources, and very much about local strategic priorities. And I think the important part of this document is that it starts to signal a greater collaboration between NHSER and ICS as a system, and very much working through ICSs rather than two ICSs, if that makes sense. That everything should happen in collaboration, and any sort of discussion on performance and improvement should happen in that way. It's very much underpinned by 70 KPIs. And they are listed, so I promise you I won't go through each one of those as we stand at the moment, but it's fair to say that each of those KPIs will also have some underlining KPI that feed into that. For me, there is a real opportunity here to start thinking about place and collaborative working, and start thinking about outcome measure and how those feed into those KPIs, which is very much where place is going to be and moving forward. And we've already heard some really great examples of that previously. So just really to note that is happening. It's a precursor really to ICS working, and whilst I think there will be some change in 2023, I suspect this is very much a framework that we're going to apply. So I'll pause there for a second, see if anybody wants to ask any questions.
Thank you, Paul, for being so concise. And you're right, we discussed it for those of us who were at F&P on Friday in great depth. Any observations from the chair of F&P, Martin?
Yes, I think what I would say is that pre-COVID, RTT was increasing, waiting times were increasing. So now that we're out of COVID and COVID has exacerbated RTT times, it's hardly surprising that we're looking at the figures we are now. Everybody is working incredibly hard across all specialisations, and all clinicians are now pulling every stop out to try and make things better. We've got clinics being worked on weekends, alternate weekends, consultants working extremely hard as well. And as Ed has alluded to earlier, the maximum waiting times have come down now to somewhere, I think we were told 44 weeks, but I think it may be lower now. But that doesn't change the fact that the number of cases are increasing. So at some point, we're not actually rowing back. There's going to come a point, I suspect, where we will reach an equilibrium. And I can't see the workforce being able to carry on the current levels of activity for any length of time, because it'll just get burnout. So obviously, for me, as somebody who's looked at these figures now for several years, there's something has to change. If we're going to get on top of this problem, there's got to be a completely different approach, which I think something Paul's already alluded to there, which is a collaborative way of working between health and social care, part of the ICS. So I think going forward, this is where the real challenge for me is going to become evident.
I certainly agree with that, Martin, and I was there on Friday, and I think it brings a sense of urgency, doesn't it, to the discussion we had earlier about getting on with the new arrangements that will bring in, I should say, much greater levels of collaboration. Paul, let me just see.
Ed.
First of all, Ed, could I go to you next, please?
Yeah, just to respond to Martin's point, and maybe I should allow Paul to do so instead of me, but you're absolutely right, Martin, because we're doing approximately 100% of the pre-pandemic baseline, whereas the conversation in the NHS is we need to be doing 130%, 140% to really make some inroads now. So what are the big moves we could make to see that step change? And we haven't answered that question, but you're posing exactly the right question that we need to answer. Otherwise, this could be a very, very long period of time where we're in this situation, which isn't going to be acceptable.
Thank you, Ed. And your paper's generating a number of questions. Shall I go through them all, Paul, before
that's fine.
Coming back to you for ease? So Frida and then Max, if I may. Frida.
Yeah, I'd just like to say, whilst we're in August, in general practice, certainly we are seeing very high levels of demand, and I am absolutely dreading the winter pressures coming. And I take your point, Martin, and I think following on from that, the winter is going to be a real burner for us in the NHS, and I am actually dreading this winter more than I've ever done before. And I don't see any change in terms of how NHS England can do this when you don't have the workforce necessarily, and you're so short of doctors and nurses nationally that you can manage what's expected of us. I just don't know. I really don't. I know I'm being really negative, but I just don't know what the answer is, and it's really worrying me.
Thank you, Frida. Go to Max, and am I right in thinking you want to come back, Ed?
Yes, please. I'll wait till the end.
Yeah. So Max, please.
Thank you, Chair. I mean, when we look at the performance, and I think you will see obviously the problems that we've got as largely as a result of the COVID pandemic over the last year, and I think actually my sense is that big parts, major parts of the health service have had a really hard think about how to provide healthcare. So primary care has rethought how it provides its services and trying to provide it in a different way. Hospital services similarly, I get the sense that they're really looking at doing things a bit differently, and that you can see that in some of the information that you've provided. I don't get that sense for mental health. I might be wrong, but I just don't get the sense that there's been a rethink, or there's been we know that referrals to mental health services actually went down in the pandemic, and there was an opportunity, I think, there, which was perhaps missed, to really rethink how we provide mental health services for our residents in North East Essex. And I think there's a big shame there, and I think it just smacks a little bit, I think, of lack of innovation, particularly regards our main mental health provider.
Thank you, Max. I'll go to Prashant, then Ed, and then perhaps you'd like to come back, Paul.
Yeah, sure.
So Prashant, would you like to come in?
Thank you, Chair. I was looking at the framework which is going to be sort of coming in for the ICS, and it was an observation, and it's a positive observation. Positive point is that in the past, children's services and mental health were all mutually exclusive of our CCG monitoring process and performance monitoring process. First time in the oversight sort of cycle, I have noticed that mental health and the children's services and maternal services are included in this performance. And correct me if I'm wrong, but I think that's a positive step where we can sort of look into whether we get the value for money, and as Max was alluding, see whether mental health sort of ticks all the boxes it has promised. Because in the area where I practice, I think 35 to 40% of my day-to-day work is now involved with anxiety, stress, mental health. And albeit they're not all tier 3 or suicidal, but when one person with the suicidal intent comes through the door, that's it. That's the end of my day. So it's very difficult to get access or any kind of help for that kind of a patient. So yeah, thank you for including this in the oversight process, maternal and children and EPIT in the same performance sort of review. So that's a positive step.
Thank you for recognising it, Prashant. I'll go to Ed and then Richard and Max. Do you want to come back?
Sorry, no, I should take my hand down, sorry.
Okay, so that's Ed, Richard, and then we must move on with some concluding remarks from Paul. Ed?
So it's just, I mentioned earlier that around the community services arrangements, and we should come back to seeing how that's settling in after a period of time. But my question was around, in a similar vein, on IAPT. And maybe Richard would want to answer it rather than Paul, I don't know, but just wanted your sense of how the transfer's gone from Hertfordshire to EPIT. And whether we're confident it's moving forward in the right direction. I know there's some narrative in the paper, but just interested in your views.
Should we go to Richard first, Paul?
Yeah, go on, and then I'll pick it up straight after.
Richard,
I'll let Paul come back on that if that's okay, because I'm not close to the detail of the mobilisation, but I'm happy to pick up offline with the team and find out more. I was just going to come back more broadly on mental health, given Max's comments. Max, happy to talk to you more offline if that's useful. Absolutely, some of what you're saying resonates. We clearly need to do more in this field, particularly given the activity is going up and up across the ICS, and we're not unique in that in terms of mental health demands that we're now seeing more than ever over the last probably 4 or 5 months, and that's popping up all over the place. Couple of thoughts though. We have got a nationally driven programme of change on mental health. So there is absolutely things happening. Maybe we need to do more at selling what is actually going on. We do have the Mental Health Board for North East Essex, I think is meeting in the next couple of weeks. So there's an opportunity there to take your challenge into that board around what more we might be able to do. As an example, we've agreed, as you know, the mental health practitioner roles for adults, the final 2 or 3 I think we're going out on. We've also agreed, Pam and I, in the last couple of weeks, that we're going to roll out similar roles for children and young people. So we're just putting the final touches to that. So although they won't be ARRS funding, we're going to go ahead and do that from within our own resource, because we absolutely feel that there is a need for that kind of role, as was demonstrated at the North East Essex Alliance Board a couple of Fridays ago. Wider on the UMS work, the children's work, again, Pam and I taken stock, I think it was the end of last week, and we're looking to do a Turn the Curve event in September around the whole piece around children's mental health, because again, following the Alliance Board meeting where there was a lot, rightly, of challenge around what more can we do collectively, we wanted to use that mechanism really collectively across the North East Essex Alliance and yourselves to look at what more we might be able to do at each of the 4 tiers of children's mental health in particular. Last thing to say is we do have, as you know, the procurement reaching a conclusion, which obviously I can't say too much on, but the new model of care that we all developed and Annie as GP lead was part of is part of the answer to what more we need to do, albeit that will take some time to reach fruition. So just don't want to leave the board thinking there's very little happening in the mental health field. There is a lot, but we clearly need to do more at joining up exactly what's happening, and the place to try and do that is the mental health board, but Pam and I can talk more offline about how we make sure we've got visibility on that work.
Thank you, Richard. Having been absent from that discussion at the Alliance Board, I'm absolutely delighted to hear the progress and action that follows that through. You mentioned the Mental Health Board, and I would find it very helpful, but the chair will decide, no doubt, to have a really in-depth update on the work of that board at our next board meeting, and also to have greater insight into some of these national initiatives that are being developed if that's something we could discuss offline.
I'm happy to do that. I think we did it. It's quite a while ago. We did do one, I think, in memory, quite a while ago. So it's probably time. I'm going to be doing one for the 2 Suffolk boards as well in September. So perhaps we do it all at the same time. We'll have a focus and then deep dive on the mental health front. Pam, you've just also reminded me, Pam D, around the suicide prevention work. I didn't know if it was worth just referencing where we're going with that, because that was something that Prashant also mentioned in terms of suicide.
He did, and it's also touched a nerve for me, given the conversation you and I had yesterday, Richard, and the ongoing concerns that we all have. I don't think the boroughs and districts are isolated on this one, but that we all have around our high position for Colchester and Tendring in the league tables, 2nd and 3rd in the whole country. And I think it's fair to say it's been very, very difficult to join up a whole range of really excellent work across the system. And I was really reassured by the conversation we had yesterday, Richard, which attempts in a very serious way to do that, and hopefully to bring that back to the Alliance Board in August. We're also doing some work at a localised level within North East Essex to try and understand why we're in this position, and to that end to give more attention to the 80% of victims of suicide that take their own lives and are not known to the system. And that seems like a really high number to me. And if those individuals are within the system, at least they get the benefit of an in-depth analysis and inquiry into the circumstances. The 80% don't. There is a coroner's report, but I'm really reassured by the work that the police are doing on real-time reporting and determined to work on how we can link that into almost like a domestic homicide review approach that really brings resources and profile and status to the position these victims find themselves in. Okay, now I've spoken for so long, I'm now overwhelmed with people who want to speak, so I need to check my order. And poor Paul, you've got so much there to respond to, and we really must get on. But I'm going to go to Martin first, then Pam, and then Paul. You must have the last word. Thank you.
Okay. Phew.
Yeah, although we talked about the massive challenges in RTT going forward, I think it's important that we don't become too mired in doom and gloom, because I mean there are successes across the board, and when we look at the performance, say around cancer, we can see the trajectories all coming back. For people who need emergency work, if you are seriously ill, you will get seen. So whilst those people requiring less urgent operations and treatment might wait a little longer, if you are seriously ill or you have cancer, then you will be seen almost to the same now as you would have been before. So I didn't want to leave anybody in some terminal pit of gloom. So we are getting there, and things are getting back to normal. And I just wanted to say there's an awful lot of good work going on, and an awful lot of hard work by a lot of clinicians, and Paul's at the heart of that. So
no doubt about that. Thanks for raising it, Pam, and then Paul.
Yeah, thank you. I think this shows the join up between sort of Richard's team and my team. It's very much about the place response that we need to have for North East Essex and pulling all those strands together, and particularly in primary care. I just want to address the point, Max, around there was a reduction in mental health referrals during COVID. There wasn't for very long, and this the acuity of patients that we saw during that time was very, very severe. So we know that our mental health trust has had bed occupancy rates higher than they've ever seen, actually, in the time that we've been working with them, as well as high levels of referrals to other services. So first episode psychosis during COVID was very, very significant, and that continues. We're doing some work with the local police services to join them into the alliance to make sure that we're managing as many patients and citizens without having to bring them to A&E door and giving them all sorts of other support. So I just wanted to make the point around place, because again, this is about the societal pressures, not necessarily just about how health is responding in isolation, but I'm sure if you spent some time as we do with our mental health frontline staff, it's been a very, very difficult period for them as well.
Thank you, Pam. And now, Paul, I'm going to ask you to do the impossible, which is to respond briefly to all of that, please.
Okay, I will try and be succinct. So, first of all, in answer to your question, Ed, my understanding is that the transition has gone pretty well. The teams are really engaged in reviewing and ensuring they move forward with the service. I've not heard anything to the contradiction of that, but I will make a point of asking that question specifically. And I think if you look at the narrative, certainly the performance figures, they look fine, although there is a bit of improvement to be made. Just picking up on Martin's point, I think when we sort of engage in the recovery piece around elective, and particularly around the Accelerate program, we always understood that there was probably three phases to that. One was, how can we push activity as much as we can by utilising private sector, by getting people to do more on the goodwill of folks and workforce, and exploring different ways of working to try and achieve essentially 100% of our threshold by July. I think I'm relatively confident that we are likely to do that based on the mid-July figures that I've seen. The second phase was always about productivity and actually what work can we do now to improve productivity of what we're currently doing. And both acute trusts have done a significant amount of work around pathway reviews, GIRF measurements in terms of the opportunities, and are in the process of concluding some of that. Equally, what is pushed to the fore, it's pushed to the fore collaboration. So we are seeing sort of a orthopedic stroke MSK board emerging at a system level to that there is collaboration working. The same on ophthalmology, the same on things like dermatology, and harnessing the clinical leadership to try and have those conversations, try and essentially manage the waiting list at system rather than as separate silos. The third bit of the conversation is really about sustainability and what else can you do? And that's quite rightly said. I think it's been some radical thinking, and we are currently having those conversations, but not quite sure what that might look like. And in order to recover the list in a particular sensible manner, we probably do need to hit about 130% of previous 1920 threshold activity, which is a significant amount of work. There are some really positive headlines, as Martin has said. You know, we are seeing a sort of our over 51-year waits drawing down as a system of about 7,000 back in May to about 4,000 and coming down in June to about 4,000 plus. We are seeing our baseline 92nd percentile 53 weeks down to 40 weeks for SDF and 44 as a system. The waiting list is growing, but it's growing much slower than it would have done if we hadn't done those measures. So again, that in itself is a positive story. And let's not forget that part of the capacity element also helps cancer performance in terms of opening up capacity. Does help cancer performance, opening around long waiters and recovery. There and very quickly, there are some risks though, which we've expressed. Workforce, Martin, absolutely is a risk, and there is a lot of work at system level going on around workforce and workforce support. We know that we are experiencing really significant pressures around urgent care as we speak at the moment, and it does feel very much that the winter's here already, which is a concern we need to acknowledge. We have a workshop tomorrow as it stands as a system to try and understand what else can we do to try and support the urgent work and sort of how we might do things differently. And all three alliances are going to feed back together with the trust to see what else we can do. In terms of mental health, we've also recognised that whilst the e-put story on paper looks quite positive, they are facing an increasing demand and acuity of patients. And again, our plan is to follow that up with a subsequent workshop to tomorrow's workshop, particularly focusing on mental health to see what else we can do. And perhaps, Martin, that's where we might start to think about maybe some of the missed opportunities you talk about in terms of how we might do things differently moving forward. And finally, the only other point I would make around mental health is certainly my sense of it is that we have a very engaged provider in ePut, but have very proactively looked at the waiting list, very proactively looked at validating all their waiting lists, looking at how they can recover their waiting list, and very much feeding back to us in terms of all the things that they're actually doing. So whilst I think it remains a massive challenge, I think we can't underestimate the amount of hard work and significant work that the system is currently taking to try and get to recovery. And I'll stop there, and I hope I've covered most of the points that were raised.
Thank you, Paul. And we certainly don't underestimate that. It's to be acknowledged and recognised, and as is your commitment and leadership to this performance challenge that we face. So thank you for the debate and thank you for the paper. Now quite a way behind in terms of the agenda, so just remind everyone that the papers have been read and move on to Jerry, Audit Committee reports. We're asked to receive and note it.
Yes, happy to take any questions, Pam.
Okay, any questions for Jerry? You're helping us catch up there, thank you. So moving on to item 12, finance and performance. We've talked a lot about that, Jane. Anything else to add to your report?
No, I don't think so, Pam. I would take it as read. Martin may want to come in, but hopefully this gives a flavour of the work that the F&P, the Finance and Performance Committee, did. As you say, we've been through a lot of the performance elements earlier in the meeting, but we also do discuss the financial position as well each month in detail. So it's hopefully this gives you the overall summary of the work that we did last year.
It certainly does. Martin, is there anything you want to add? No? Any questions?
No,
okay,
very concise.
Thank you. Thank you. Any questions? No? So let's move on then to item 13. Over to you, Pam. Excuse me. Excuse me.
Thank you. So this is our in public meeting about primary care. So the paper is obviously taken as read. I'm happy to take any questions, but just to update on the list closures, we have now agreed a plan for the Harwich area about opening up the lists there with some estate changes that needed to be agreed to support the practices. So we're working on a plan to ensure that practice access improves on the peninsula of Harwich, as well as obviously working with other practices. One of the practices in Clacton has now indeed opened its list again, and that was one of our practices that lost a significant member of staff during COVID. So we understand that that had a huge impact on the running of that practice, as a significant figurehead in Dr. Mirza in the Old Road practice. So he is much lost colleague from the Clacton area, but we've supported the practice to reopen their lists. So that just leaves one more practice to support in the Clacton area to open their list. So and also, obviously, that report covers the significant success of the sign up with the pharmacist triage service that we've heard a lot about in our presentation from our medicines management team in this very meeting. So I'm happy to take any further questions on the contents of the paper from colleagues now.
Thank you, Pam. Any questions for Pam? Just leaves me to thank you for the work that's been done, certainly in supporting the practices that you've mentioned. Thank you, Pam. So moving on then to the Quality Committee report, item 14. So I'll turn now to Lisa. I won't be able to offer any comments as chair of that meeting because I wasn't able to be there last time, but over to you.
That's okay. That's not a problem. I chaired it. I won't go through the whole paper. There's some key points to note around maternity services and ophthalmology at ESNEFT, which is all in the paper, so I won't go through that. I think the other thing to add, obviously, from a quality perspective, the majority of our discussion was around the demand and capacity issues from acute community care and our ambulance trust providers. And the other area that we had some significant discussion on was the number of escalation calls that we're currently all as a quality team involved in, where we have placement breakdowns for people with learning disabilities or looked after children or children requiring tier 4 access, and we're usually having 2 to 3 children or people with learning disabilities requiring escalation calls across the system each day now. So it's a significant amount of work, and I guess my thanks to ESNEFT and to UMES. They're doing an amazing job, our providers, in supporting some of these children in the acute sector, and the in-reach crisis service that NELFT are providing is really good. It's really exemplary. But obviously these children need to get to the right place. So that's probably one of our main quality concerns. But I won't go through all the individual points in the paper, although Pam, I was really pleased and wanted to point out the IHA improvement, because I know it's often something that you're concerned about, that we have seen some really sustained improvements on the initial health assessments for looked after children. Thank you
for recognising that and updating. Thank you. We have a question from Max.
Actually, it was about the initial health assessment. I wasn't quite clear whether there had been improvement. It does look like there was an improvement, but I couldn't see the figures that said there was an improvement. I could see that the processes that were in place to make sure they're improved. But there has been an improvement, has there? Or maybe I'm reading the report badly.
You're on mute, Lisa.
Sorry, I think the thing that's slightly confusing is because we had a large paper, and it's got the background from 2019 in there, where performance was really poor. But then it shows that actually throughout 2020 to 21, it's still not where we want it to be. But when you compare it to 2019, there's a significant improvement, and actually the numbers of children that aren't having IHAs within the time frame are very small now.
Okay, that's great.
Thank you, Max. We have a question from Ed.
It was more of an update, but Lisa may want to add to it. It's just the transforming care performance for people with a learning disability being supported out of inpatient settings and to live in the community is very strong in Essex. I think we came 5th nationally in terms of our performance, and the same over the border in Suffolk. They're kind of neck and neck. So Lisa, I'm assuming that as part of that Essex picture, North East Essex has, contributed well.
Yes, and so obviously our Phil Brown, our Essex County Council colleague, leads on the Transforming Care, or Health Inequalities Board as it's called now. And it's well recognised regionally, Essex's performance in supporting people with learning disabilities to receive care closer to home. Obviously, as we know, North East Essex has a high number of supported living providers and residential settings for people with learning disability, which is great actually for Essex, because it means that people are able to stay in Essex. We are actually refreshing our LD improvement plan for North East Essex. We've just had the leader annual report come through, which does demonstrate that across Essex there are some improvements that need to be made to support people with learning disabilities, and we're just kind of looking at what that means for North East Essex.
Thank you. So we'll note that report. Max, am I right in thinking your hand is a legacy hand?
It is, sorry.
That's fine.
I'll be a bit more disciplined next time, sorry.
That's fine, just didn't want to miss you out. So thank you, Lisa. We'll note and receive that report. So just moving on, Pam, for the next 3 reports, I think are down to you. So could I turn to you for the Alliance Committee overview report? And I note that we have, obviously, we have our chair for that committee here, who may want to offer some comments as well. So Pam.
Yeah, certainly. So I think what this report gives you is an insight into both the Alliance work as well as the decisions that are made at system level. So we're really pleased with the scope of this committee now. It's really getting into full swing and seeing the right decisions and the participation of both general practice in that space as well as system and partners. With reference to the Alliance work, and Pam, as chair, you may have a comment on this in your capacity as strategy lead for the Alliance, but we are getting some significant traction now on our neighbourhood teams rollout. And this morning we've agreed an investment plan to enable our Alliance to really come to life at sub-place level, so down to our 6 localities, starting with Central Colchester as our first place to roll out quickly, followed by the other areas across the Alliance footprint. What the aim of that is to really start to connect up the wider determinants of health, as well as the health and care of our individuals that reside in the Central Colchester patch. Rapidly testing the theory around working together in one joined up team between local authority, health, social care, voluntary sector, and with our community leaders, taking a real place-based approach, but from an asset-based community development approach. So including all of our green space, including access to sport and exercise through our local delivery pilot run by Sport England. So I'm really pleased that that's been a project long to come to fruition due to the changes around the community services contract, but we now have the right leadership on that, and I'm grateful for Pam's challenge and constructive criticism to get us to the right place. So we continue to work on a communications plan to communicate to the public why we would be bringing all of those services together, and what it will mean for both general practice as well as other services. But it must be recognised that as statutory organisations, we work with the same individuals very often, so joining up our services and making us more efficient will help from a safeguarding place to a well-being outcome. So we're really excited about that. The structure and governance around the Alliance is currently now being reviewed in light of the white paper to take us to the next stages of maturity, to enable us to be delegated by the ICS Partnership Board in the future to deliver locally the strategy for the Alliance. And also we are doing a significant piece of integration work to enable our organisations to benefit from working together and deliver better outcomes and joined up outcomes for our local citizens. So very exciting, alongside the housekeeping and the statutory decisions that need to be made in that space. Hopefully the paper's given people a scope of the infrastructure and the decisions that we're making in the Alliance. Happy for Mark to contribute to that, and Pam.
Thank you, Pam. If I could just come in first, if I may, Mark, just to pick up the points that Pam made about the neighbourhood work. Yes, it's been a long haul, but we are now gaining momentum. I think, although I wasn't at the discussion this morning, the paper I read, I thought said it all about why we're doing this, and I think it might be worth bringing a focused look at the Central Colchester pilot as soon as it's up and running and we've got some learning to this board. So thank you for listening, Pam, and for the opportunity to work collaboratively. Mark, any thoughts as chair?
Thank you. No, I'd only pick out 2 specific points where we talked about mental health for young people. And that has been referred to already today. And I just wanted to make sure we were linking up the 2 discussions. The Deputy Director from Essex for Children and Young People was there and was committing to providing the Alliance Partnership Board with an update and a full kind of holistic look at things. I just want to make sure, from what Richard was talking about earlier, that connects up and that happens across all of our different sort of front-facing committees, and to make sure as many of us get invited if we want to come to be part of that. Thank you.
Thank you. So thanks, Pam. Can I ask you to move on to the Area Prescribing Committee now? We've noted that report.
Thank you. Yeah, so you've got the annual report here from the Prescribing Committee as well as the minutes of the most recent meetings. Again, testament to the working across the ICS's join up and the delegation that's given to this committee. Prashant may wish to give comment about the decisions made, but this enables consistency, safety and joined up approaches as articulated by the medicines management team earlier in this meeting through this committee. So I think it's important to note that, again, this committee has moved swiftly where required to agree COVID vaccination determinants as well as switches from different medications and guidance around NICE guidance that's published. So it's a very effective board that and committee that enables the decisions to be made with the right membership. So Prashant, is there anything you'd like to add as a member of that group?
Not really. You've touched on most of the things. I think all those issues were highlighted earlier on by Lisa and Ogie. The priorities for the region were sort of acted upon fairly swiftly, especially with PGDs and PSDs being disseminated for the workforce for COVID-19, and then antimicrobial prescribing, hypnotics and diazepam. There's a separate website for that. And I think the new drugs coming in, some supply issues and stuff like that, which is day to day. And strategically, I think the plans were made quickly and the three systems was sort of communicated promptly. So that's all I have to add. I think there's nothing else to that.
Thank you, Prashant, and thank you, Pam. Any other observations on this report?
Hopefully the annual report gives a good scope of what this committee does in a good, concise document. So please keep this committee in mind for other decisions.
Thank you. So your final report, Pam, item 17, the procurement update, please.
Yeah, so since we last met, obviously we've concluded and transitioned some procurements and the contract's gone live, particularly for our community services. And it is noted the request that we will provide a focus on the performance of that contract post bedding in. So we usually give 6 months for the transition to happen fully, but I'm happy to call that forward so that this committee can see the benefits of the decisions that were made to transition that service. So we will prepare that either for the next meeting or the one after that. So I'm happy to do that. So there's a list of procurements that have been considered, some of which were paused around because of awaiting the boundary decision, which will now be reviewed, and others that are being progressed. So I'm happy to take any questions, but this is the standard pipeline and progression procurement document that we produce for this committee. In partnership with Attain, who are our independent procurement advisors.
Thank you, Pam. And I'll just bring in Max, please.
Thank you, Chair. Pam, the diabetes service, running a contract to the end of March, being incorporated within the NICS contract. Can I just sort of explore that a little bit? I mean, the service that we've got currently running now is a successful service, is it not? Is it not performing well? And why? I mean, is it basically going to be taken away from Suffolk, the Suffolk Fed, who are providing a good service? What is the reasoning behind that?
So it was part of the procurement notice around the NICS contract. Suffolk Fed were awarded as a subcontractor in that arrangement. We now have to do the administration of that award within the contract. So we're working as an alliance governance group to ensure that happens, but it is absolutely recognised by us as commissioners, that it's an excellent service that has changed the outcomes for people locally and taken us from the lowest decile when we commissioned it previously to the upper decile of diabetic outcomes, made a significant change to the health and life expectancy of the diabetics locally. And I think what it's most importantly done has supported our general practice, where there is constraints around specific workforce and access to supporting the patients in the depth that they need to. So that is very much recognised, and it's been through a process. It's been out to the market, and it will be concluded by the end of March.
Thank you,
so
Pam.
may end up still being subcontracted. It may end up still being may end up that way. Yeah. Okay.
Yeah. So we're working through that.
Yeah, that's fine. Just want to understand it. Yeah, for sure.
You're content with that answer, Max?
Yeah, that's fine. I just wanted a bit of understanding. Yeah, thank you.
So thank you, Pam, for taking us through those reports. We'll move on now to corporate business and governance, and over to Amanda for 2 or 3 items. Could we start with the staff survey update, please, Amanda?
Thank you very much, Chair. So following on the staff survey report presented to the last governing body, please find attached an update on all the actions that we continue to take to address the many issues that came through from our staff last year. And as you will see in section 2, what we've identified are all of the actions 17 plus. And as at the middle of July, where we were in terms of actually actioning a lot of the actions that we have committed to, along with our staff and various teams and the organisational development group. And as you will see, some of the actions have been addressed, some of them are currently in plan, and some of them are coming on stream in the coming months. But I hope you will agree that we have got good traction. There is a good sense of commitment with our staff, our directorates, and also through the organisational development group. And what we're hoping for is through a positive set of actions pertaining to last year's survey, when we repeat the survey this autumn, that we can improve on last year's staff findings. But I'm very happy to take any questions, Chair.
Thank you, Amanda. And as the report points out, we are required as a governing body to keep this matter under constant review.
Yes.
So therefore, there will be opportunities along the way, either in the governing body's agenda or in board development sessions, to do exactly that.
Indeed.
Okay. Thank you very much, Amanda. So no questions on that. Could we move on then to item 19, the board assurance framework, please, Amanda?
Thank you very much, Chair. So here is our board assurance framework, which identifies our top risks as a CCG that we continue to address and mitigate. And as we can see, we have something like 11 key risks that are of red rating that we continually manage as a collective. And since we presented the last governing body, you will see that we've actually added 2 new risks this time. The first is around the maternity services at ESNEFT, and the second risk is pertaining to the ICS white paper. Both of those new actions have a director lead, and we are continuing to mitigate. And as we will have heard previously throughout the meeting, we have got a lot of work and a lot of plans that we need to be taking forward to address the ICS white paper, particularly now that we have received the boundary conclusion for Sydney. There is a lot of work planned through the governing body, but also through our various staff forums once we have received the HR framework, which we are expecting very soon. And that in itself will require a whole programme of work to be worked through alongside not only ourselves, but our trade unions in terms of addressing the staffing issues required between now and next March. I will leave it there, Chair, but very happy to take any questions.
Certainly a great deal of work to do, as you say, once we've got sight of the framework, which I assume will come to the board once we've had sight of it and had the chance to work through the implications. So I'll just bring in Ed at this stage. Ed, please.
Yeah, I was just reflecting on Frida's earlier comment about winter. She was saying quite rightly, you know, demand is incredible at the moment, and we're in August. What's it going to be like in the winter? And I guess it's covered implicitly in the risks, but I wonder whether we need to have a specific risk around winter, given where we are with demand.
That's a really interesting point, given the concern that's been expressed today, but also elsewhere about the impact of winter. I would open that up for discussion and support your suggestion, Ed.
Thank you.
Be happy to include that as a third new risk. It certainly allow us to keep it under review, wouldn't it? And to constantly monitor progress and a rapidly changing situation, no doubt. So in the absence of comments, we'll accept that as an additional risk. Paul.
Yeah, thank you, Chair. I think that would fit into the conversation I had with the team recently around making sure that the winter plan is cited to our governing bodies, particularly given how difficult this winter is going to be. So that fits in nicely. Thank you very much.
Yeah, I agree. Thanks for the suggestion, Ed. And can I assume then that we're content with the assessment of risk as identified in the report and the now 3 new risks that we're taking on board?
Thank you.
Looks as if we are. So that's noted, and thank you, Amanda, for that report.
Thank you.
And the final item before any other business is health and wellbeing. So clearly a clear connection between this and item 18. And you and I, Amanda, have had the chance to speak about this. I wonder whether you'd just like to kick off with a brief introduction.
Yes, of course.
The role that I've been invited to take on, and then I'll comment if I may.
Thank you very much, Chair. So last year, when the National People Plan was issued, it helpfully suggested that all organisations, through their respective boards, should identify a board level champion who would undertake the role of a health and wellbeing guardian. And for Suffolk and North East Essex, all organisations, including our 3 CCGs, have now identified such a role. And for North East Essex CCG, that is indeed Pam, who has kindly agreed to be our board level champion to ensure that all things health and wellbeing pertaining to our workforce as an entirety is kept under watchful eye and more. Now, this is the first time that we brought a verbal update to our governing body, and what Pam and I would like to do going forward is to provide something more by way of a written report so that the governing body can be assured, or otherwise, that the CCG is actually doing all it can to support the wider health and wellbeing agenda. But I also think it gives us opportunity as board members to be challenging, to be questioning, and to asking ourselves as a collective, are we doing enough to support the wider health and wellbeing role and the like? Now, in terms of the CCG specific items regarding health and wellbeing, we have had for quite a while now a joint health and wellbeing group that works across Suffolk and North East Essex. It's well attended with lots of representatives from each of our directorates. They come together as a collective and consider what further initiatives, support and the like we should be offering our staff. In addition to that, we provide regular updates which are quite detailed, whereby we offer additional support, and that could be through training, it could be mentoring, it could be workshops, it could be mindfulness sessions. And if of interest, I'm very happy to share a recent communication that we've sent out to our staff, which just highlights a lot of the diverse work that we're doing to support the health and wellbeing of our workforce. But I think going forward, it will be really helpful if we could convert into a written report, which basically provides greater assurance to governing body around the health and wellbeing agenda. Thank you, Chair.
Thank you, Amanda. And although I'm very happy to take on this role and do my best, I don't think I've made a very good start, because Hassan always gives the board a break and I haven't, and suggests that you jump around and take some exercise, and I haven't done that either. So I hope I get better over the coming months, but I think an update would be very welcome. We are almost at the end of the meeting, so there's no point in me doing it now, is there really? But I'll hand over to Matt's comments on that suggestion. Thank you.
Yeah, thanks, Amanda. I think the CCG has been really good at health and well-being actually over the years, very recent years, and we must continue to build on that work. And I think I've certainly been inspired by the mental health champions and the attention to the well-being of our workforce. I think the difficulties probably over the last year, but particularly the fact we've not been in an office, and we've been working remotely largely, and it's been difficult to sort of support that mental health and well-being in a remote way. I would also like to add in primary care, and that's important. Should be part of that strategy as well, and hopefully that there is a group, there's a GP wellbeing group that meets every couple of months to look at general practice wellbeing, and we have a strategy that's come out of that, and we're continuing to meet and work on that. So I think primary care needs to be definitely included in all that, because I think we need to spread that good work amongst our primary care workforce.
Thank you, Max.
Right, Max, and given the challenges of the last year, and then on top of that, tough winter and more organisational change, I don't think there's ever been a more important time to focus on it. So, Ed, would you like to come in?
Yeah, I'm sure colleagues may be aware of this, but I was in Aspen House earlier this week, and Jane Taylor was showing me the new wellbeing room that's been created, which is a really fabulous environment. I think every detail's been thought through. So I think when the staff are back fully in the workplace, or to some degree, I think that would be a really nice facility for the staff to have.
Thank you, Ed, and thank you, Amanda. So we'll move on to any other business. Item 21. I haven't been pre-notified of any AOB, but Martin, would you like to come forward with an item?
Yeah, just a very quick one, really. It's to say that Jenny Kearton is leaving the CCG on the 20th of this month and off to be Deputy Head of Finance, I believe, at Mid-Suffolk. I'd just like to say on behalf of myself and the F&P committee to thank her, really, for all her services over the years. Quite rightly, the CCG over the last several years really has gained a reputation being incredibly good at managing its finances, and that's in no case down to been on top of her game all the time. And she's one of those rare people that when she raises a potential problem going forward, comes up with the solution as well, which makes it very much easier to deal with. So I just really like to thank Jenny on behalf of myself and the F&P team, and I suspect everybody else, and wish her well in a new job.
I think you speak on all of our behalves. I think Jenny had the knack of making really difficult, complex issues just seem manageable. She had a great skill in giving us confidence that solutions could be found. So yes, we all wish Jenny very well and thank her for her support for the CCG. And that's really reflected in the chat, as you will see. So thank you, Jenny, and good luck. So that brings us, no other items? No, I don't think so. That brings us to the end of the meeting. And we'll meet again in October, so the summer will really be over then, won't it? And into autumn and into more change. So thank you all for today's meeting, and enjoy the rest of your day. Thank you. Bye-bye.
Thank you.
Thank you.